Welcome to the Advancing PAH Care video series. This series includes key opinion leaders who discuss new information in the 2022 ESC ERS treatment guidelines for pulmonary hypertension and how these recommendations can be incorporated into clinical practice in the U.S. Some of the topics to be covered in this series include risk stratification, the right heart beyond pressure, ESC ERS treatment algorithms, and individualized patient care. With support from UT, the PAH Initiative provides non-branded disease education for the PAH community. The initiative worked with PAH experts to identify the content for this program.
I'm Dr. Franck Rahaghi, Chair of Pulmonary and Critical Care at the Cleveland Clinic in Florida and the Director of Pulmonary Hypertension Program. I'm joined here by my colleague, Dr. Mandras.
I'm Dr. Stacy Mandras, the Medical Director of the Pulmonary Hypertension Program and a transplant cardiologist at Advent Health in Orlando. In today's discussion, we will review the updated treatment algorithm that was published in the ESC ERS Treatment Algorithm Guidelines released in 2022. Highlights from the guidelines include clarified treatment goals, strengthened need for proactive, risk-based approach to treatment plans, the recommendation to use baseline and frequent follow-up risk assessments, an expanded risk assessment approach to include right heart parameters, and lastly, added guidance for patients with cardiopulmonary comorbidities. So Franck, with those key points in mind, let's talk broadly about the PAH treatment approach before we explore specifics around the treatment algorithm. What are your thoughts?
Yeah, so I think one of the hallmarks of this version of the guidelines is actually frequent risk assessment. In the past, we used to focus on patients' functional class and symptoms, and really, truly, risk assessment is a much better way to determine where the patient is in the revolution and what do they need next. And again, another approach that we're going to take is not just be happy with necessarily the lower risk, but actually look for actual clinical improvement and having clinical improvement in mind. So let's get into some specifics, Stacy. What do the guidelines recommend for initial management?
So baseline risk assessment is recommended at diagnosis, and options include either the ESC ERS 3-strata method or, like we use in my practice, the Reveal 2.0. And these are validated risk assessment tools that give us a much more comprehensive idea of whether the patient falls into a low, intermediate risk, or high risk. And treatment options depend on where they fall. Most patients, it's recommended start on combination therapy up front. We learned from the Ambition trial that patients who are started on combination ERA PDE5 do better than patients who are started on monotherapy with either one alone. The guidelines recommend as initial therapy that patients who are low or intermediate risk are started on this combination of the ERA and PDE5. That said, patients who have severe hemodynamic impairment, either by echo or hemodynamics with the right heart cath invasive data, despite being intermediate risk, these patients should be considered for parenteral prostacyclin as part of their upfront combination therapy. For high-risk patients, these patients truly should be offered parenteral prostacyclin up front, either IV or sub-Q. It's a conversation that you have to have with your patient, as there may be reasons why some patients are better candidates for one or the other. And then lastly, patients who have certain cardiopulmonary comorbidities like hypertension, obesity, these patients may also be considered for monotherapy up front. But these are patients that you need to monitor closely. So with this overview of initial therapy recommendations, let me ask Franck, in what ways does your follow-up management approach either align or differ with the guidelines?
Sure. So actually, to a great degree, they do align. So it's really important to have treatment goals, which we already had discussed, involve getting the patient to low-risk status within a year or as soon as possible. Frequent risk assessment, usually every 3 months, seeing the patients. And, it's really important to be aggressive. It's kind of akin to the golden hour of sepsis, where you have a limited time to get the patient better. Studies have shown that if you don't get them to low risk status within a year, they will have poor outcomes. And that's why we sort of use the risk assessment frequently. And in the follow-up, we now use the 4-strata risk assessment. In the past, and using, for instance, Reveal 2.0, we sort of, in our minds, used to divide them in the sort of the low intermediate and high intermediate. And here now the criteria have been formalized for that, because we know that the low intermediate, as you explained, and the high intermediate have a differing way of following the patients. Now, in addition, the guidelines have suggested, and we believed in it, that you have to also consider right heart parameters. As an example, I had a patient that was low risk technically, but had a really dilated right ventricle. And this young woman with 2 kids, I figured that if something happens to her, she has no reserves. So even though she was at low risk, technically, I escalated her care so that the right ventricle would shrink, and indeed, that's what happened. So this is an example of how to incorporate right heart parameters on top of the guidelines. And then, again, treatment follow-up is key once you start something, to go back and check and see where the patient is clinically and where the risks are, so that you could escalate or continue the care. The next question is, how do you determine when and if to make changes in the treatment plan, Stacy?
So, as you said, everything is based on trying to achieve a low-risk strata. So if I see patients on follow-up, even on the very first follow-up, if I don't see them improving from intermediate or high risk, coming down towards low risk or achieving low risk, then we have to escalate therapy. If at baseline they're low risk and they maintain low risk at follow-up, we maintain their current regimen. If they were at increased risk, whether it's intermediate or high risk, and they achieve low risk at follow-up, they stay on the therapy that they're on. If they're intermediate low risk, I would argue that is not good enough. I think most of us would argue that is not good enough. Every patient should, if possible, achieve low risk status. And so if they come on follow-up and they're intermediate low risk, then those patients deserve some type of treatment escalation, either transitioning from the PDE5 to the guanylate cyclase stimulator, or addition of some form of prostacyclin therapy, whether it's oral, IV, sub-Q, or in the US, inhaled, which is not available in Europe, but for us offers a nice additional tool in our arsenal, as it tends to be very well tolerated and demonstrates improvement in 6-minute walk and functional capacity. For patients who are at intermediate high risk, those are patients, again, who should be escalated. And in that stance, I would say those are patients who should be offered parenteral prostacyclin. Again, they have a choice between IV or sub-Q, and that's a conversation that has to happen between the provider and the patient. Sometimes there are other things that go into play, things like support, distance from the treatment center, et cetera. So again, this is very much individualized therapy, and that includes for patients who have the cardiopulmonary comorbidities that we discussed earlier. These patients need to be followed very closely. Frequent follow-up is important. Patients are seen sometimes every 3 months. Our sicker patients may be followed every 1 to 2 months. So we've gone through a lot of information here, Franck. Thank you so much for all of your insight. Would you please summarize some of the key points that we've covered?
Well, Stacy, thank you for your brilliant comments and your perspective. So basically, if I want to summarize it, I would say that pulmonary arterial hypertension management requires proactive and routine monitoring and risk assessment and goal-oriented therapy based on the risk, and with the objective of getting the patient to low risk within the first year. Thank you for joining us today for this discussion. The discussion on the treatment algorithm is only part of a series of videos that we encourage you to check out. So with that,
goodbye.
Bye.
Thank you for watching. This program is part of a series of videos about how PAH management has evolved in recent years. Topics covered in this series include the importance of hemodynamics, the role of risk assessment, the PAH treatment algorithm, and considerations for the treatment of PAH. For more information on PAH, please visit resourcesforpah.com.